Thank you everybody for joining us for our Hawaii Economic Association July online webinar. My name is Lesley Gabrielle Harvey of the Hawaii Business Consultancy and Board President of the Hawaii Economic Association. Special thank you to those who donated to our student fund. Your donation will support HEA's scholarship fund, student workers, and student attendance and access to HEA events, among other student initiatives, ensuring our events remain accessible to the next generation of bright minds. Thank you. Thank you also to those who have contributed to our general fund. Your generous contribution allows us to continue to offer these events without operating at a loss. Economic and resources. This month's topic, Reopening Hawaii, featuring Dr. Mark Mugiishi, will provide information on Hawaii's public task force, coronavirus response, and recovery efforts. Following Dr. Mark's presentation, Mike Robinson will moderate the Q&A discussion. Please use the Q&A button at the bottom of your screen as seen here on the slide. If you encounter any technical difficulties, please send a private chat to Sierra, who may be able to help troubleshoot. And should we have any technical difficulties along the way, please bear with us. We've recently upgraded to Zoom webinar to better facilitate these events and have prepared for a smooth day today. At the end of today's webinar, we'll ask that you let us know how we did through a short feedback form that you'll receive after today's event. It's also been posted in the chat. If you registered, you'll receive the link by email, and you'll also receive the slides and recording of today's event next week. If you haven't yet registered, please do so at heajuly2020.eventbrite.com. Next month, I hope that you'll join us for our monthly event titled Reopening the Hawaii Tourism Economy in the Age of COVID-19, featuring Sumner Lacroix, Professor Emeritus in the UH Department of Economics and a research fellow with UHERO. That also will be a webinar, and details will follow. Now, before I turn it over to Dr. Mark, I'd like to provide some brief introductions. Mike Robinson, who will be moderating today's Q&A discussion, is the Vice President of Government Relations and Community Affairs for Hawaii Pacific Health, where he has served for the last 20 years. In his role, he oversees the legislative, advocacy, and community engagement activities across the healthcare system. Hawaii Pacific Health is the nonprofit healthcare system comprised of Kapi'olani Medical Center for Women and Children, Palimomi Medical Center, Straub Medical Center, and Wilcox Medical Center on Kauai. Mike remains engaged in the community in a variety of settings and involved in a number of organizations who share a common mission of creating a healthier Hawaii. He currently serves on the boards of the Hawaii Public Health Institute, Bike Share Hawaii, March of Dimes, Alzheimer's Association, Laniakea Pacific Foundation, and of course, the Hawaii Economic Association. Mike also serves as chair for the Healthcare Association of Hawaii, Advocacy Committee, Leadership Committee member for the Transform Hawaii Government, and Legislative Committee member for the Hawaii Business Roundtable. Mike is a graduate of Maryknoll High School and earned his bachelor's degree in economics and government from Cornell University. He received his MA in economics and an MBA from the University of Hawaii Manoa and a JD from the William S. Richardson School of Law. Dr. Mark Mugiishi has served as the president and CEO of HMSA since February 2020. For the majority of his career, Dr. Mark has practiced and taught surgery in private practice and in association with the University of Hawaii John A. Burns School of Medicine. He has served HMSA in a variety of capacities since 1995, from part-time medical director to consultant. In 2015, he joined the leadership team as Executive Vice President, Chief Medical Officer, and Chief Health Officer. In addition to his leadership at HMSA, Dr. Mark co-founded the Endoscopy Institute of Hawaii and the Eye Surgery Center of Hawaii and was a medical director at Hawaii Technology Accelerators. He was a general surgeon in the state for nearly 30 years and was associate chair of the Department of Surgery and director of surgical education at the University of Hawaii Medical School. Dr. Mark currently serves as chair of the Iolani School Board of Governors, where he coached varsity basketball at Iolani and holds the distinction of being the winningest high school basketball coach in state history. And in 2010, coached the All-American Nike Jordan Brand Classic game in Madison Square Garden. Dr. Mugiishi was a producer of the Broadway musical Allegiance, starring George Takei and Leah Salonga, which ran at the Schubert Longacre Theater in New York City in 2015 to 2016. He earned his medical degree from Northwestern University Feinberg School of Medicine. And with that, I will turn it over to Dr. Mark.
Mahalo, Lesley. Aloha, everyone. Thank you for having me. It's a pleasure to be able to speak to HMSA's role in the recovery of Hawaii from COVID-19. And, you know, the whole process of dealing with this unprecedented pandemic starts with relief. Everybody together as a community first begins with trying to make sure that we take care of relief, and then recovery, and finally resilience at the end, where we hopefully come out stronger than before. And I'll start from the beginning by just saying that from how we took care of this virus, we are kind of like the shining star of the United States right now. Some of it was skill, a little bit of it was luck and circumstance, but the bottom line is that we've done quite well. I think the main reasons for that are, number one, geographically, we're an island with a big moat called the Pacific Ocean surrounding us that prevents rapid influx and uncontrolled influx of the virus from people driving into your state lines or anything like that. But also, it's very important to note that we were very quick and early to close our borders with our 14-day quarantine, and also very quick and early to go to a work from home, stay at home kind of order from the governor. And all of that, enforced by the mayors, was critical, I think, in maintaining a very flat curve from the beginning for the spread and prevalence of COVID-19. Now, having done that, all of us who are in public health understand that taking care of the immediate public health concerns is very critical, but also the secondary ones and the ones that will impact the next generations of people who live in Hawaii is equally important. You know, probably the biggest determinant of public health in the long game is economic adequacy. And when you lack economic adequacy, all of the health-related social needs accelerate and your public health will deteriorate. And so it's really, really critical that once we're safe and we feel that we've done a good job at taking care of the first wave of this infection, that we figure out how to recover and then how to develop resilience going forward so we can attack this. So that was HMSA's reason for getting involved. We got involved because our purpose is to improve the lives of our members and the health of Hawaii, and helping with the relief and recovery from this is really mission critical for us. And so we were asked by the state Speaker of the House at the state legislature if we would be part of the task force that would help create a public health recovery task force of public and private sector leaders that would help with this. So if we can go to the next slide. This is the task force we wanted to cover, and here was the purpose of it. It was a public health recovery task force that was a coalition of leaders and organizations from a variety of places, from government, from business, healthcare, nonprofits. So basically public-private partnership. We also got expert health advisors from across the islands and the US mainland. And it was really intended to generate a strategic and unified and evidence-based approach to manage a phased recovery so that we can, you know, like I mentioned earlier, we did a great job initially of relief, and now we had to recover. Key to all of this is public transparency, so you can rebuild public trust and confidence in the effort. So we thought that the best way to do this would be to build an alert model that had clear, concise measures that the public could follow. They could understand why certain interventions were taking place, and when those are released, why those are being released, and what's the rationale for all of this. Keeping people apprised of community health status would be critical to getting public cooperation. So that was one of the key things that we wanted. So we did work together to provide public and private leaders throughout the state with this scientifically supported data to help ensure well-being. So next slide. kind of the two questions we wanted to ask ourselves is, first, how do we safely reopen the Kama'aina recovery? The local economy, that are the restaurants, the retails, commercial businesses. And then after that, how do we safely open our tourist economy? Right now, our visitor economy probably accounts for 30 to 40% of direct economy, but there's a lot of indirect as well, because as all of us know, those things above, the restaurants, the retail, the commercial, the businesses, you know, there's trickle-down effects of our traveler industry that have impacts on those. So we really do need both in order to have a full economic recovery. And anyone who's run a big operation understands that if you're going to do something huge, you have to really have a lot of support in four main categories, and that's people, process, technology, and policy. And they all have to be carefully thought out and planned in order for you to generate a successful operation. So next slide. This was a partnership. We needed to be coordinated and aligned with all of the people involved. You see in the bottom left-hand corner, us, we even made ourselves a logo as the Hawaii COVID-19 Public Health Recovery Task Force. We were partnered with the state of Hawaii, especially the governor's office, the state legislature, the House and the Senate. And then the upper right is HIEMA, which is the Hawaii Emergency Management capability that gets activated during emergency proclamations. So under Major General Hara and his team, we were partnered with them. And then finally, bottom right is the recovery navigator. So under Alan Oshima, reporting to the governor's office to ensure recovery and resilience in our economy and in the way we come out of this pandemic. Next slide. So after a couple of months of really good work by a lot of good people, and we had input from our health system partners, Hawaii Pacific Health and Queens, from our economic partners, the banks like First Hawaiian Bank and Bank of Hawaii, from the academic healthcare world, from the School of Nursing, all of those, as well as all of our government leaders who were involved. We were able to come up with a matrix that's critically important to help develop, as I mentioned earlier, a community response matrix that people can follow, that they can understand the rationale. And here it is. So just to kind of go through how we got to this, first of all, there are really four basic levels: red, orange, yellow, green. The blue level on the bottom is when we have a vaccine or herd immunity and can stop worrying about COVID. That's a year away. So in the meantime, we're playing in the four: stay at home, safer at home, act with care, and recovery community health levels. Now, how do you decide what level you're at? That's easy, transparent, that can be measured, that the public can understand. So we looked at two categories of health determinants that could help determine which risk category we're in. The first is disease activity. And disease activity can be broken down into two categories: the severity of the disease and the prevalence of the disease. So you need surrogates to measure those things. And under severity, we chose the number of hospital cases per day. So if you look at, for example, in red, you would see that in red, the number of hospital cases per day threatens hospital capacity. So in that case, you would worry about health system capabilities, and that would keep you at a red level. Going down, if a hospital has to think about activating their emergency plan, then that would be orange. If they have to just have a plan, that would be yellow. And if they can proceed in their normal circumstance based on the number of cases, then that would be green. Prevalence, the surrogate we used, is the median number of new cases per day per week. So this is a trend number. It's how quickly or slowly the number of cases, new cases per day are growing. And more than the number, it's more about how those cases are coming to pass, whether it's uncontrolled community spread or whether it's happening in clusters that can be contained, or whether it's truly very, very sporadic and easily contained. So the different categories demonstrate how you would take the number of new cases per day, the trend of that, and determine whether or not you have uncontrolled community spread, or whether this, it's in a cluster that you can contain. Finally, capacity is critical, because we all know that until we have a vaccine, we're going to have cases. And probably as we gradually lift restrictions, that number of cases will increase a little bit. And the key is, can we handle it if we do? And this is healthcare capacity. And there are really three major components of healthcare capacity. One is acute healthcare capacity. So hospitals, do we have enough hospital beds? Do we have enough ICU beds? Do we have enough ventilators to manage serious illness? So that's the healthcare supply column. The other thing you need in order to manage COVID-19 is you need the capacity from a public health standpoint to control the disease within the community. And the two things you need for that are the ability to contact trace, which is the ability to take a positive case, determine how many people that positive person has touched, and manage those touched people. That's contact tracing. And in order to do that, you have to be able to test everybody, and that's diagnostic testing. So it's very important that there's enough capacity based on the number of cases to contact trace and test all of the people that we need. Now, all of these factors together create the risk level that you're at, and based on that, there's a response. So depending on your community risk level, does it mean that only essential activities would be allowed? That's red, stay at home. Does it mean you need to be safer at home, orange, where low risk activities, we're gonna start to allow those? Can we relax more in yellow, where moderate or moderate risk activities can be released? This is kind of where we are today. And then eventually we can get to green, where even the lowest risk activities can be opened. So this is, if we can go to the next slide, that's the matrix that helped determine the risk level we're at. Underlying all of this is that no matter which risk level we're at, safe practices need to continue to happen at all levels in order for us to make sure that we don't regress. And those are the basic things that people have heard all the time about. Proper hygiene, staying at home if you're ill, wearing masks, cleaning surfaces, making sure you're socially distancing from people, protecting the highest risk individuals, and making sure that people who are actually sick are isolated and quarantined. So if we do that, regardless of which level we're at, we can at least stay at that level, if not become less restrictive and moved out. So we saw some of these levels and how they panned out. As I mentioned, we're somewhere between yellow and moving toward green right now. So most medium risk businesses are now open, and we're starting to slowly open some of the high risk businesses, such as gyms and theaters. Next slide. Under all of this, in order for us to make this work, there are 4 pillars of public health that have to be in place in order for us to manage the disease at whatever level we're at. And those are the 4 here: screening, testing, contact tracing and surveillance, and quarantine. And what our public health task force did was really create the momentum to make sure that we had adequate infrastructure in our state in all of these areas. So partnering with the Department of Health and other state agencies to make sure that all of these things are adequate to protect us as we reopen. So screening, basically, this is the idea of having a comprehensive network all throughout our islands, whether it's private, like people asking you questions or checking your temperature before you go into a business, to airport screening as you travel inter-island and filling out paperwork for that. Those types of screening activities. Testing, it's very important for us to be able to test people and make sure that we have the capacity to manage all of this. When we first started this, we were doing a few hundred and we were really not adequate. And now, very, very proud to say we're up to about 5,000 tests per day capability here in the state, with results within 24 hours. So these are all done within the state. And so with this, we're able to really test all the new cases, as well as all the people who have been contact traced as close contacts with the new cases. So with that, we're able to do the next pillar, which is contact tracing. So the Department of Health has grown their capability by growing to 500 trained contact tracers, which give us the ability to, within 24 hours of notification, being able to identify all the people who may be exposed and to be able to test them or quarantine them as appropriate. And this is very important, and it really allows containment of infection, and it doesn't allow single infections to spread wildly throughout the community. And finally, quarantine. We're getting better and better at this, between the HMSA's ability to use the National Guard and others to enforce quarantines, to the counties and our local county enforcement with the police forces. We have become much better at isolating and quarantining people as necessary, and enforcing it, which is very, very important. Under all of this is the need for personal protective equipment. Again, at the beginning of this, we didn't have enough, and we've gotten to the point now where our supply rate, our resupply rate, is definitely greater than our burn rate. Thank you to everybody in the healthcare system that worked diligently on this and made sure that we're in a good place for that. Next slide. So where are we today? This is actually a week old, sorry. I had to make the deck, so couldn't get to the last week. But you can see that you can easily make a dashboard to explain why we're in where we are in. Right now, the severity, this is again, like I said last week, there were 7 new hospital cases. That is well within our capacity, so we do not have to activate any surge plans. The prevalence last week was a median of 8 new cases per day per week. That's a little higher this week, but that is not anywhere near endangering our healthcare capacity, which you can see on the next slides. Our available healthcare capacity, we're well within that, and we're well within our capabilities of contact tracing and diagnostic testing. However, with the slow kind of growing of the ability of the number of cases per day, it's probably prudent to just move a little cautiously as we move from one level to the other. One of the things you never want to have happen through all of this is to have to go backwards. Next. All of this turns into what actually happens. So this is a sample reopening status dashboard that turns the various business sectors and operations into how they would open during the different community health risk levels. So as you can see in yellow, most things except the large venues and clubs are open to some degree, and some halfway open, so maybe at half capacity with protections in place, some at 3/4 capacity. And as we move along, more and more things will open with less and less restrictions. Again, I can't reiterate enough the column on the right that safe practices at all levels are necessary for us to continue to make progress in the right direction. Next slide. So that's that. And, I'm sure there's going to be questions on this. I'm going to go onto the next portion of my presentation, which was HMSA's specific role as a health organization in our stabilization and recovery. But afterward, please do write your questions down, even on the first part, and I'll answer them kind of all together when we get into the Q&A that Mike is going to facilitate. So next, I wanted to specifically talk about HMSA as a health organization, independent of our role on the Public Health Recovery Task Force, what we've been trying to do during the pandemic. And I'm going to start, since this is an economic association, just going a little bit of an overview of the economics of health financing during a pandemic. So if we go to the next slide, I'll spend a little bit of time on this so you can understand what an actuarial forecast would be. And this is truly a forecast, what you see here. It's how we looked at what might happen when we were starting to see COVID take place. So first of all, turn your attention to the dotted lines that are in the middle. There's a revenue baseline and there's an expense baseline. And in health financing, the intent is to always have the revenue baseline be a little bit higher than the expense baseline so you can put money into reserves. And the importance of reserves are that, number one, they help mitigate an underwriting cycle. So some years you're going to get your actuarial predictions wrong or your underwriting predictions wrong, and you're actually going to take a loss. So you will need reserves to protect against that. And then maybe you're going to have pandemics, like, who would have thought? So we have one now, and sometimes you have to have a buffer for that. The adequacy of your reserves are typically measured in the healthcare industry by a number called risk-based capital, which is the amount of your reserves relative to the amount of risk you're taking in your insured covered population. The idea is to try and get it somewhere around 2 to 6 months worth of money in reserve. And we in Hawaii are we at HMSA are just above 2 months of reserve. So even though you see big numbers in reserves, they're really only protecting you for 2 months worth of expenses. So you really do try and always get that little margin to make sure. At HMSA, we shoot for 1 to 2% of that margin. As a not-for-profit, there really is no reason to try and get more than that. What happens in the middle of a pandemic such as the COVID-19 is that, I'll start with the revenue, is that the revenue will start to fall. And the reason for that is people become unemployed and they fall off the employed roles, and you start to see that. This was buffered a little bit by the Paycheck Protection Program that's part of the CARES Act, where people were able to be furloughed, where they maintained healthcare coverage from a commercial standpoint because of protection by the government and revenue infusion of revenue to small businesses. There will be an expected second dip of revenue decrease when PPP money runs out at the end of July, unless there is another stimulus bill that comes in. So you see that starting to, see that starting to drop. This green line, again, was a forecast. It's actually turning out to be true. The other reason is that given the fact that businesses are in distress, companies that want, like HMSA, who want to keep people on coverage, we did offer premium payment programs where people who couldn't pay could have deferred payments throughout the end of the year. And so that also drops revenue on an ongoing basis. At some point, as the economy starts to recover, you expect that to come up. It will probably never come up for a while anyway to the baseline revenue. And part of the reason for that is there's a shift of commercial membership to Medicaid membership. Here in Hawaii, we call that Quest. And the revenue per member per month is slightly less in these government programs than they are in commercial. And so the revenue line never quite reaches the baseline. So that's the green line that you see. The red line is the expense line for what you expect. And initially, what you see is a decrease in expense because health systems and the health delivery areas start to defer elective procedures and start to be unable to service more routine types of visits. Because of the pandemic, people are staying home, right? So only emergency services are happening. Now, if you're New York, you have a huge pandemic peak where the expense in ICUs and critical care is quite high. We had to plan for that because at the beginning, we had no idea if we were going to turn into New York. We were very lucky. What actually happened in the Hawaii experience is that our red line never reached actually the green line. So our expenses always stayed slightly below the revenue line. So we were very, very fortunate there. Eventually, that will come back. People and now the health systems have started doing elective procedures again, and also deferred care comes back. So people who had to not have their total hip replaced during that time, maybe they're going to start having it now. And so deferred care tends to increase utilization slightly more to the capacity of the healthcare system. Also, as you can see, there is always a chance for a second wave, or as we're seeing now in the US, just an extended first wave. Pandemics can be unpredictable. So there is still a chance that just even from the initial onslaught of COVID, that there will be an increase in utilization to care for that. So when you look at all of this, this is the kind of macroeconomic picture that we're trying to model out and stay ahead of the game as a health organization. Next slide. So what we did was we created a COVID-19 task force within our own organization. Can you go back one slide? Sorry. Yeah. And the goal of that task force was to do a few things. It was to make sure that we were approaching this internally correctly and externally correctly. And internally, we wanted to create a safe work environment for our employees, both at home and those that had to remain on site. Externally, we wanted to make sure that we were able to communicate across all of our stakeholders, which for us are members, providers, employers, and then our own HMSA employees. And then we needed to make sure there was continuity of critical business functions for our stakeholders. So how do we address the financial challenges that are being faced by our members, providers, and employer groups? It's actually rare, except in the case of pandemics, where everybody gets hammered. And that's kind of what happened here. All stakeholders suffered hardship, and we had to help address all of those issues. Next. So these are all the subcommittees we had to create. Streamline care, I'll just call out that as the first one, because the rules of the game change weekly, daily, between guidance that we get from the federal government, what Blue Cross Blue Shield is doing across its network, to what Hawaii needs as a community for ourselves. We had to figure out what's the right thing and the right model for how we deliver care and pay for care here on our islands. And besides that, there were all these other things that had to happen. And so we had a variety of people sitting on all of these subcommittees to address all of this. Next. Some of the samples that they came up with, things that we needed to do to support our members. We were waiving all of the cost shares for COVID-19 treatments and services, covering the full costs of diagnostic tests, waiving pre-auths for anything that's related to COVID-19. We got rid of our prescription limits so that people could get plenty of medications that they could need if they needed to keep it stockpiled. And then we did increase access to telehealth by waiving cost sharing and starting to cover the non-HIPAA compliant types of telehealth like Skype and FaceTime and things like that, that the federal government said they would waive enforcement of HIPAA for those. Next. For employers, this group really hurt because 30%, 40% of our employer groups are tied to the visitor industry. This was a big struggle for them. So we needed to continue to provide coverage to them with flexible payment options and other sorts of types of assistance we could give them so that paying for health care wouldn't be the reason why people lost coverage. We also formed a CARES Act subcommittee that would link the employer groups with the related federal resources and support to make sure they could access what they needed. And anybody who really did finally get to the point where they did have to lay employees off, we worked with them to make sure that each of those individual employees could get another type of coverage, whether it was Medicaid, Quest, or whether it was an individual ACA plan. Next. For providers, we stayed in constant contact with our tertiary health systems to make sure that all their needs were met, and we supported them in whatever way we can. Payment transformation was something we started in 2016, paying a fixed monthly payment to primary care docs for their attributed panel rather than fee for service. And this allowed them to continue seeing their patients in a variety of different ways, whether it was phone calls or telehealth or any other way, getting the same revenue from HMSA that they always have. And we were paying for telehealth and expanded access, as I mentioned earlier, through our expanded telehealth programs. Next. And for our employees, I think anyone on the call who's run a business knows that everyone had to go through all of this, that we had to move carefully and cautiously to make sure that we could continue to do our business and continue to support our customers while maintaining the health and safety of our employees. So in the beginning, that was moving most of our company home. So I'll be transparent and honest and say we're pretty slow-moving, conservative, stodgy organization. And so the idea that we were going to take the vast majority of our 1,900 employees and get them out was a daunting task, but we did. And at our max, we got pretty much about 90% of our employees working from home, 80 to 90% working from home. We're lucky that we had just upgraded all our IT support to be able to allow that to happen. And then, we had to change the kinds of metrics that we used to make sure that we were meeting all our needs. And when we were confident we were doing that, we kind of stayed that way until the state started reopening. And then we had to figure out how we carefully start moving people back if it made sense. If it didn't make sense to move them back, maybe we keep them there. If it made sense, let's move them back. So we're now in that process of moving them back, maintaining all the socially distancing recommendations of 6 feet and good protections. That means you don't have enough space, right? Because you now have, you have to change. So we've had to get innovative with shared spaces and shift rotations and alternate scheduling, and we're working on that. And then, and like I mentioned, an entire group of people will probably permanently be working from home. So we'll probably continue to be relying on a hybrid of in-person and remote work within our organization. And I would just say, next slide, before we go to question and answering, is there's been a lot of terrible things that's been associated with COVID-19, but maybe if there is a silver lining, if there is a good thing, it kind of reinforced, I think, the fact that innovation is still alive and well, that people can adjust and adapt, that the resiliency of the human spirit is still alive and well, that we can take this on together if we do it. And as I've worked with people within our own organization and people in other organizations and all the other leaders from around the state of Hawaii, I've been really energized, refreshed, enthused about how much people are determined and perseverant to make sure we come out of this stronger on the other side. And I think if we keep doing that together, we will shepherd this through until we do have a vaccine. Everybody's working on that. That's a big deal for the whole world. My high school classmate from Iolani School runs the IVI Vaccine Institute in South Korea, and they are in some phase 3. So I get a little bit inside baseball from him that besides him and some of the other big ones in Great Britain and Pfizer and some others, we have a decent chance of early in 2021 to have a reasonable vaccine going. And so with all of that, let's just kind of hang in there and keep pushing forward. And I think we can get to the right place. So with that, Mike, I'm going to turn it over to you to moderate our Q&A.
Thank you very much.
Thanks a lot, Mark. First question is from Jack Siderhout. Hi, Jack. Question is, Mark, how comfortable are you that the testing and other arrangements for visitors after August 1 will provide adequate protection from a resurgence?
Anytime you try and do something like that, I think what you want to rely on is a layered screening process. The kind of metaphor I use is that, if you look at a filter and it has big holes in it and you try and pour water through it, a lot of water will go through. If you take about 10 of those things and you layer them all on top of each other, even if each one has kind of a big hole on it, when you pour water, it like kind of holds the water back. So that's the idea behind this. It's not just testing, it's screening, it's thermal screening, it's it's the test, it's and then it's continued surveillance at the hotels, continued surveillance at the attractions. When you put all of that together, I have pretty good confidence that we'll be able to control the influx of any infections. Now, all of that being said, I'm basing my thoughts on the kind of disease prevalence as it exists today. Whatever screening, testing capacities we do, whatever process we put in place, let's say they're 99% good. That's good for a certain number of baseline things, but if you suddenly make the denominator 100 times bigger, then 99% may not be as good enough. for something that big. So I think we will have to keep an eye on what's happening in the rest of the country, and kind of determine whether we keep moving forward based on that.
Great, thanks. And we have a number of questions, so I apologize for anyone who, if I don't get to your question, I may need to edit some of them in the interest of time. A related question, Mark, as a follow-up is, how does HMSA and the task force plan to identify the asymptomatic COVID population as the economy opens up?
It is very hard to identify the asymptomatic COVID population. I mean, it's estimated by some people that about 35% of all actual COVID cases are asymptomatic. That is hard. So it's hard to identify them. And that's why we have the matrix that you have, where really what you're trying to do is incentivize proper public behavior. Look at the entire population. Are we actually controlling the prevalence in our entire population? And are we contact tracing, where you will catch a lot of the asymptomatics? Are we actually contact tracing people who have close contact with somebody who is positive? Because that's, at the end of the day, that's actually where the asymptomatics come from. At one point in their life, they had a close contact with somebody who was positive. So the more we are effective at contact tracing them, the more we will find these people.
Another question from an anonymous attendee. What are your recommendations for allowing trans-Pacific visitors into Hawaii beginning August 1st? Should all visitors, even those from countries with low COVID numbers, be pre-tested?
I mean, I know the governor is working on potentially trying to do deals with some countries to waive the 14-day quarantine with those if there's a reciprocal arrangement. I'll defer to him and his administration about how easy that will be to do from a State Department perspective, because as you know, we are still part of the United States, even though we kind of sit in the Pacific Ocean. So when you start dealing with other countries, I think you have to think about what federal law and federal regulations will say, besides just what the state of Hawaii thinks. In terms of from other states, if you look at like, can we legitimately operationalize saying, if you're coming from North Dakota, I'm just making this up, where there's a very low transmission rate, would we treat them differently than if they're coming from Florida? I would say that's a nice concept and idea and concept. It's probably not feasible. Number one, because again, federal laws and discrimination rules, but more importantly, just all of those people are going to fly through California. They're going to stop in LA and come from LA to here. So I don't know how you actually tell where people came from, where they originated from.
This is a question from Norman. Mark, what agency or agencies are responsible for tracking the PPE and testing inventories, as well as tracking the burn rates for each?
Yeah, from a statewide perspective, it is the Department of Health. They're responsible for that. So they get information on all that from the Healthcare Association of Hawaii, HAH, tries to consolidate that information from all its members, and then it gives it to the Department of Health, and the Department of Health is responsible for overseeing that.
Another question, 20 new cases announced today. Do you see this as a trend?
You know, there definitely was a trend of an increase from the time that we started lifting the restrictions. That's to be expected. I mean, you weren't going to go from, we were between 0 and 5 for a long period of time, and then we started opening, right? We started opening restaurants, we started opening bars. Things are starting to open. It's unrealistic to say we're not going to get any of it, that we're not going to get an increase. And that's why it's important that we follow the matrix and try and understand, is the trend worrisome in terms of healthcare capacity? So it's not an absolute number that makes you worry. It's a couple of things. One is, are we approaching healthcare capacity? And the answer to that right now would be a definite no. We are well within healthcare capacity for all three segments, for the hospitals, in terms of hospital beds, ICU beds, ventilators, plenty of that. In terms of testing and contact tracing capacity, plenty of that. So we're good there. How do you know if you're starting to get worried? Like there's no real good answer to that, but what a lot of people use is doubling times. Like, are the number of your cases doubling over 2 or 3 consecutive weeks? And we actually don't have that either. So when you look at either of those types of kind of metrics that are typically looked at across the country, we're still in good shape. All of that being said, we definitely should not become complacent, because if 20 goes to 40, like you have a doubling time, and 40 goes to 80, then we would start to be threatening our healthcare supply. So everyone should be reinforcing for themselves, their families, their friends, even just people that they meet. Let's be good about this. We've been the best in the country. Let's keep that way. Social distancing, wearing masks, being responsible with hygiene and sanitation. Mike, I think I can't hear you anymore. Sorry.
I was on mute. Apologize.
Okay.
Question from Jeffrey Harris. Why doesn't the task force also focus on improving nutrition and ensuring adequate exercise?
Our task force was specific to the reopening of the economy for COVID-19. HMSA as a company, as a health organization, we are 100% committed to nutrition and exercise. It's definitely part of the whole concept of well-being. It's probably out of scope for our task force, but I'm with you. I'm all for making sure that we emphasize as a community nutrition and exercise.
This is a question, anonymous. How has Hawaii been in terms of usage of masks and social distancing?
I don't know if there is a actual like metric that you can use to tell, but all I know is I look at what I see on YouTube and Twitter and Facebook and everything else of what's happening elsewhere in the country, and we're pretty darn good compared to what else I'm seeing. So.
This is a question, let me see this, from Pia Arma. Do you think we need to be more informed about the disease itself? As I understand it, it is not like the flu, but worse.
I think information is key to this whole thing. And one of the things that we really try to emphasize with our partners at the state and all the rest of us in private sector is the essential need for adequate communication and public information spreading. I think we're getting better at that. We're not good enough. I think there still are a lot of gaps in knowledge out there. Now, one of the things I'll just say is that this is a novel coronavirus. It's new. It's never been out before. This is the first time it's been around in the history of mankind. So we don't know all the answers. So yes, we should all become better equipped to understand it, but we don't actually completely understand it anyway. But to the degree of the information as we get it and we understand more and more about it, it is really, really important that this is communicated to the public in a way that the public can understand, because we're not going to really control this until we all do this together. And that's going to require everyone understanding what we have to do together to control it.
Chris, a question from Sumner. Question is, Mark, where did the figure of 30 to 40% of the visitor industry plus trickle down multiplier effects come from? DBED, in an excellent study, puts the industry at approximately 17 to 18% plus 7% multiplier, which is 25 in total.
Okay, I'll defer to Sumner. He's probably knows better than me, but for whatever reason, I kind of thought that that's the number, the 30% number is what I heard from you, Haro. And, you know, whether it's 30 or 20 or whatever it is, the fact of the matter is, I think now, because of the impact to our visitor industry, we do have the highest unemployment rate in the country as a state. So we have the lowest COVID rate, the highest unemployment rate. One's great, one's terrible. We need to fix, you know, the terrible one, I think.
Question from Lauren Kim. Going forward, is there a need for a future fundamental restructuring or re-engagement relationship for the public health system with private healthcare system based on lessons learned from COVID? Or was the existing Hawaii model, quote, good enough given our outcomes? Good question.
No, it's a good question. I actually really believe strongly that a public-private partnership is always better. And I know Lauren knows enough to know that we had our challenges because we're not used to working with each other and we're not used to the cultures at each place. And it was a great opportunity to try and get more synergy and synchronization together between the public and the private sectors. I hope we get many, many more opportunities to do that. We're going to be stronger as a state if we do that together more and more. Yes, we ended up with a good result. As I started off my talk, part of it was good public health policy that began. Part of it was luck. I mean, let's just call it what it is. Being part of an island makes it a lot easier for us to manage this disease. But there's going to be other times when we're going to be disadvantaged, and the more we can work together, the better off we'll be.
This is a question from Joy Barua. Hi, Joy. Question is, as the state's largest insurer, what is HMSA's timeline forecast for Hawaii health insurers to return to, quote, normal revenue levels?
I would say it will probably not be till 23. The economy has to kind of recover because I think, first of all, the unemployment rate will drive up Medicaid numbers. That's one point. The other point is employers will be struggling to recover. So until they get back to their pre-COVID numbers, they'll be clamoring for affordable health plans. So we'll probably have to creatively come up with affordable options for them that they can manage with. Again, that will mean less revenue. So all of that together will mean less revenue probably till 23, if I had to guess.
This is another good question from Norman. Mark, what are the myths, realities regarding antibody testing that needs to be clarified to the public?
Yeah, I think, antibody testing, number one, many of the tests are not good. They have really high inaccuracy rates, whether it's false positive or false negative types of rates. But so that's one point, and that's an important point. So if you're going to have one, just make sure it's FDA approved, because many of them are not. But the other thing is, right now we're not 100% sure what clinically relevant information it gives you, because it tells you whether or not you have an antibody, which tells you whether or not you've been exposed. It doesn't tell you whether you're immune. So nobody actually understands the level of antibody response that you need to have in order to be immune from the disease. So even if you have antibody, does that mean you can't get it? Unknown yet at this point. So I think that's the main thing you have to worry about, the antibody testing.
This is a nice question from Chantel Gota. Mark, have you observed or do you expect there to be an even greater shortage of providers, primary care and specialists? And will HMSA be able to cover telehealth from mainland providers?
So a few thoughts. First is we do worry, of course, about adequacy of providers. I mean, one of the things that COVID-19 has done is it's accelerated every trend that existed in the world today. It made it kind of like accelerate a little bit. So Hawaii is short of providers, and we need to improve in that regard. So the fear, of course, is that COVID-19 will accelerate or enhance that shortage even more. We haven't necessarily seen it in our data. Like, we haven't gotten a lot of people who've closed their offices, based we can tell on this, or at least they're still filing claims or collecting money from us. So we think that they're still there. But it's definitely something we have to pay attention to, and we have to help those providers continue to work in an altered environment. That's why, I know I'm not an ostrich that stuck my head in the sand. I know our payment transformation program has been criticized at times by different people for different components. I feel like at this particular time, some of its value was most on display because we were able to make sure that primary care providers during a time when people really could not come on a regular basis to see them in person, we were able to keep them open and keep them accessible to people. So the other thing, going to the telehealth issue, telehealth was slowly gathering steam, and again, COVID-19 accelerated that to an incredible degree. The amount of telehealth is amazing. Many people doubled, tripled, quadrupled their capacity to do telehealth. We're hoping that some of that sticks even after telehealth. We're seeing some regression back to inpatient visits now, but some other places, Mike, your organization, I know you're getting like close to 50% of your visits are now being done by telehealth, and that's just amazing for Hawaii Pacific Health to do that because it allows better access, it allows more convenience for the member. If it can be conveniently done, that'd be great. And for the telehealth issue about mainland providers doing it, it does have to do with just laws that we'll have to pass about licensing requirements, being able to provide care to people in our state. So we'll have to work on all of that in order to make sure its access is more robust.
Do we still have time, Lesley, or are we at the end?
Let's take one more question and then we'll close out.
This is actually a really nice question to end on, Mark. It's a question from Kirk. What unexpected transformation in terms of the delivery of care will determine HMSA's approach to their partnerships with providers and healthcare systems in the face of the COVID crisis?
Yeah, I think there were a lot of wonderful transformations. We just talked about telehealth, which was probably the biggest and most obvious one. I think the other transformation, again, that we were starting to talk about was this idea of an integrated delivery system where the payer and the provider are integrally linked at the hip so that we're financing healthcare in the way it's delivered. I think that became more and more obvious that that's more and more necessary. And, my relationship with the leadership of your organization, Mike, with the leadership of Queens, and our organization's ability to converse more, work together more, and actually solve problems together more, gave me great enthusiasm and hope and optimism for the future that we're going to be more integrated. And I think that is going to be the biggest transformative thing that happens for our state in the next couple of years.
Great. Thanks.
Thank you both. And thank you everybody for joining us today. We hope that you'll consider regular attendance at our monthly events. And if you've enjoyed these, please consider annual membership at the low rate of $40 per year, which provides discounted access to our paid events, such as our upcoming conference in October. Special thank you to Mr. Mark and Mike for that discussion today. And thanks to Sierra, Reen, and Paul, who work behind the scenes to coordinate the event. Thanks to our returning attendees and those who joined us for the first time. We do hope that you'll give us feedback here on our feedback form, which can be found at tinyurl.com/HEA July feedback. It's also in the chat. And we hope that you'll consider joining us next month for our August event, Reopening the Hawaii Tourism Economy in the Age of COVID-19. Have a great rest of your week, and we'll see you next time. Thank you.